glitches again. The laptop got changed, so my lecture is in the previous laptop. In the opening remarks, I just forgot to mention all the faculties who have come here. Seeing Amita Maheshwari, I forgot everything. She's ideal person for, ideal image for me. I just also want to thank Dr. Amrita ma'am, not being an oncologist, to speak on a topic like this. It was a great thing. And other faculties, Dr. Ankit, his lecture was very good. Dr. Surbhi Garg, you had taken a very good lecture on breast. And Dr. Priya Ganesh and Dr. Sailesh, they are on the flight, and Dr. Uh, Rachna Dubey is there. Her lecture is after mine lecture. I'll be talking about a very untouched, undiscussed, and neglected topic, which is VIN. And Dr. Ami, Dr. Aarti ma'am, our president, Dr. Aarti, she was our, Aarti beside you, madam, she was our student from GCRI. So these are all my various areas of expertise. Vulva, a most disputed organ. It is one type of, it is an organ. It is a neglected area. And I consider it is, one of my skin specialist friend used to say, it's a no man's land. Because the skin people don't want to go to the vulva, and gynecologists don't want to come out of the vagina. So the vulva remains unattended area. A gynecologist treat everything in the vagina, cervix, and dermatologists, they don't go there. And as an oncologist, I and Amita also will know that we end up having patients with the skin specialists have done all type of thing, and they come with vulval growths. And one patient, urogenital, did a cystoscopy, everything, but there was a huge vulval growth which was neglected. So these are the issues. Now vulva has become a big momentum in last 2 decades because of the cosmetic, thanks to our cosmetic colleagues and aesthetic gynec. In Thailand and the west northeast part, they say the male don't know that the vulva is a darker area because of all bleaching and everything. They don't know women have hair on vulva. And this is a wall of vulva where it is in the Germany, where the aesthetic gynecologist, what he did, he took 400 women, gave them a cast, and he made a wall of vulva. There are 400 varieties of configuration of vulva. So this is a wall which is there in Germany. And this I know because my cosmetic friend, she refers my patient to me, and she talks about all this thing. And vulval bleaching and rejuvenation and many things are going on. Being an oncologist, my main area is VIN, warts, vulval lesions, vulval cancers. If you see, there are around 40, 50 types of vulval lesions, from benign, pre-malignant, skin lesions, and vulval cancers. VIN is known as, it is a synonym of cervical CIN, that is vulval intraepithelial neoplasia. Vulva is a very complex structure. It has skin, scumum, mucoskeletal junction, vascular, neural, and endocrine system. It varies according to the age of women, and during menopause it also shrinks, and it needs a multidisciplinary approach. Vulval problems are more, but women are very shy about it. All women, regardless of age, will have vulval disease. Symptoms may be mild to severe. They will not approach unless it is intolerable, and will they go for a medical advice when they have chronic, painful, or disrupts their daily life, affects their sexual life, and scare of malignancy. Vulval intraepithelial lesions are rising because we know, because of the HPV, and because our society is changing. There is modernization, there is development, and there is freedom of sexual behavior also. So lesions are increasing, especially in young women also. So incidence of vulval epithelial lesions are increasing. I will now say VIN, that is vulval intraepithelial lesions. It is seen a bimodal peak, once seen in a younger age, 4 to 45, when a woman having HPV infection, she has the same peak in the cervix. And in the later age, where these are non-HPV related VIN, lichen sclerosis, that is white lesion of vulva, which is seen in postmenopausal women, and they also present VIN, which is having poor prognostic. This is the UK graph. You can see the incidence of vulval lesions are increasing Mainly, we have learned many things of vulva. Last 2-3 decades, many things we have learned from it. Many research has been done, and because of the colposcopy and understanding various terminology, the lesions, we are now able to identify these lesions. If you look into the terminology, vulval lesions are divided into 3 categories: vulval intraepithelial lesions, vulval cancer and Paget disease, and vulval dystrophies, that is known as white lesions of vulva. This all topic is a one-day seminar. I am only going to talk about one thing, that is vulval intraepithelial lesions. Two topics I am not going to discuss. Now this is a newer classification of VIN. Earlier it was known as VIN 1, 2, 3 and VIN differentiated. Now the new the International Society of Study of Vulvovaginal Disease has classified into 2 categories, that is low-grade lesions, high-grade lesion, that is usual type, which is HPV related, and DVIN, which is non-HPV related. Every low-grade lesion also is a pre-cancer condition and has to be treated. There are again 2 different types of vulval lesions. What is the 2 different in a high grade? One is usual type and one is dedifferentiated. The usual type is seen in the younger woman. They are HPV related. The cancer burden is less. Low rate of progression. Risk is low. While the DDYN is seen in the menopausal woman, not HPV related, and it is usually with white lesions of vulva, 80% of cervical cancer burden, and increase the risk of recurrence. You see, if the vulval lesions are untreated, 80% will progress to cancer. But if they are treated, the progression is only 4%. So you look into the etiology, the UVIN is HPV related, and DVIN is non-HPV related. This is only for prognostication. Whenever you get, it's very difficult to identify. But younger woman, you always believe it is HSIL of vulva. The clinical profile, the younger age group, multiple sexual partners, and it may have multifocal lesions and unifocal lesions. In the older age group, it is usually unifocal lesions and they may have multifocal lesion, which is less. Now what is the importance of these lesions? Now this is the pathway of the developing of the different type of high lesions in the vulva, younger age group, and particularly if you want to find out, we do P16, P53 and Ki16. Usually it is positive in the UVIN and P53 is negative, so it is a good prognostic tumor. While as DVIN, the P53 is positive, is a bad prognostic tumor, and usually P16, which is a marker for HPV, is negative. So this is the pathogenicity of the different type of VIN. A similar small lesion is a focal unilateral lesion. These are the multifocal lesions. Now what is the importance? Unilateral lesions, unifocal, 28% will have invasive. So if you see a small single lesion, please treat it. Otherwise, they are likely to develop into cancer. Multifocal lesion, the invasive is very, very less. So multifocal lesion, you can do a multi-modality treatment, but unifocal should never be neglected. So these are different type of VIN lesions are there. Once you will have a habit of looking, you can see different type of patchy lesions here, this type of lesions. This is a lesion which is in the inner circle of vulva, and these are patchy type of black lesions. Sometimes we get scared, such type of lesion can be seen in a mole, or we can see a darkening of vulva, but we have to differentiate, and that comes with the practice. So diagnosis is very important, clinical importance. You have to look into the vagina, you have to do the skin, growth, patches, or even you have to evaluate cervix and vagina. Does colposcopy is required, or we say vulvoscopy is required, and do we evaluate cervix? It is necessary to look into cervix also, and vulvoscopy is one of the best modalities to identify vulval lesions. To examine the vulva, we have to know the anatomy, the outer anatomy, which I'll be discussing in detail in the vulvoscopy description. Vulvoscopy is a magnified view. We apply acetic acid as we do in a colposcopy. Acetic acid is 5%, but vulval skin is thick. So what happens? It will take time to appear the acetocyte areas. We see blood vessels, surface configuration, and the topographic. You have to mark what type of lesions you are seeing. We see the 3-ring vulvoscopy, and we should also take the biopsy. Don't do excision in vulval lesions, because doing excision, it is same way. You will not know what to, if you want to go for conservative treatment, it's going to be difficult later on. So this is a 3-ring appearance, the outer ring, the middle ring, and the inner ring. Outer ring, whatever lesions are there, mostly that are dermatological lesions. Middle and inner ring are the lesions where we see the VIN maximum. So the outer ring is the area which covers mons pubis, labia majora, and the perineum. And mostly you see the dermatological lesions and lichen sclerosis. The middle ring has labia minora and interlabial fold, and what you see is chronic irritation and reflex pain syndromes, and you see minor VIN changes in this area. This is the middle ring. This is the video, but probably it is not running. The inner ring is the vestibule, periurethral area, posterior fourchette, and hymen remnant. And the acetic acid apply on this particular link to see the abnormal areas. And you can see the VIN areas highly enhanced in this particular area. This is the area where we have to differentiate between the vulval dynia or vulval irritations. After doing three vulval ring vulvoscopy, we have to differentiate whether it was normal or it is a functional, like vulvodynia or vulval, what we can say, vaginism, or we have to find out the pathology. And we have, this is the documentation. This is a form where you do a vulval mapping. This is a very integrate, what we can say, systemic examination of vulva, which is required in cases of vulval lesions. And such type of vascular patterns also you will see in a colposcopy, vulvoscopy. White lesion of vulva I am not going to touch, but there are 3 varieties, lichen sclerosis and mixed type, and each of them can progress, especially if the lichen sclerosis is there. So you have to biopsy such type of women and keep them under close surveillance. This is one of my case. I did the first vulvoscopy in 2011. It was a white lesion, but after doing a vulvoscopy and applying acetic acid, I can see the abnormal area. I biopsied and it came out to be a VIN1, and I did the excision. This is the second case. You can see all white patches here. This patient had itching over vulva and discharge PV. She went to a doctor. They did all type of treatment. Ultimately, her uterus cervix was removed, but her symptom did not regress. When she came to me, I saw all this. I did a vulvoscopy. All these patches were seen. You see in the inner side of the labia, there were patches. I took a biopsy. It came out VIN. So this was the surgery which done. And later on, after 1 year, she has well healed. She's around 72. So we did not do most cosmetic. Otherwise, we can do a cosmetic surgery in her case. Toluidine blue test is also a good thing, where you can apply toluidine on the skin, and the skin which stains is an abnormal. It is the opposite of iodine test. The punch biopsy should be restricted, and only when you see the abnormal proper lesion, you should apply local, and there is a instrument where you can take this biopsies. So VIN, do a punch biopsy or incisional biopsy, but never do an excisional biopsy. Once you have the biopsy, then what next? Management is mostly surgical, but medical management is there. Once there is a large lesion or in young women, and when you want, but you have to rule out malignancy in this women before going to the medical treatment. Surgical managements are different, excisional from laser to cold knife biopsy and leaf biopsies. And in medical management, the main thing is IMSCON mode, which can be applied at the bedtime and for 16 weeks, and definitely there is a regression of lesions. You can see such type of lesions where they near the anus, such type of lesions can regress. Podophyllene is another solution, but you have to apply it in your OPD, and you cannot tell the patient to apply it, and then you have to wash it off after 3 hours. This is a second patient of white lesion of vulva. You can see the abnormal area, and this came out to be VIN, and I did an excisional biopsy, and that excisional of that biopsy, usually in white lesion vulva, we never go for any treatment, only we give steroids, but this came as VIN2, so we had done an excisional biopsy. Now this is a very interesting case. She is 32 years, HPV 16 positive. I did a colposcopy, there was CIN2 lesion, but she had reaching over vulva, and vulval also there was a lesion. So I did a leaf biopsy, leads of the cervix, and this thing was excised with the laser, and this came out to be VIN1. So this patient is under follow-up. This is a patient which had come with multiple warts, and it's not my subject, but just to highlight, she had taken all type of plasma therapy and platelet therapy and multiple wart excision and laser, and then the cosmetic doctor called me, and there were warts everywhere, and we went and did a total excision of the skin from the vulva and the anus. And this everything was removed, and it came out to be warts only. There were no CIN, but her healing also was good. She was around 76 years old female. So all this lesion you see on more on the elderly group. This is a patient of vulval lesions. Instead of doing a biopsy, because being on experience, directly went for an excision, and it came out to be vulval carcinoma in situ. So these types of lesions are there on vulva. Medical therapy in a younger woman, in a multiple lesions, especially in the clitoris, because we know clitoris is a very important organ for sexual orgasm. So in such type of lesion, you better go for medical therapy, but we have to rule out malignancy, cancer, invasion, before giving a medical therapy. HPV DNA testing is always advised because all these things are interrelated. So it is necessary to go for HPV testing. Can we vaccinate them? Definitely, because vulval intraepithelial lesion like CIN are preventable, and if you treat them and vaccinate them, probably the future infection will not progress to cancer. So nanovalent vaccination is recommended. There are different types of even data available where it shows that after treating vulval intraepithelial lesions, even anal lesions in homosexual, you can give vaccination, will definitely prevent further consequences of HPV related diseases. And our concern for vulval is that by giving vaccination, you prevent 100% warts. 100% warts you can prevent it by HPV. Now this was a girl doctor of physiotherapy. She had such type of warts, and again the cosmetic doctor called me because it was inner side of the vulva and vagina. We did a laser excision. Her HPV was negative. And because I insisted, though her HPV is negative, I want to do a vulvoscopy. After 3 months, you can see the lesion here. Meanwhile, in vulva, the HPV infection regression is very less. In cervix, it is 80%, but in vulva, it is 40%. So such type of HPV infection in vulva has to be properly followed and surveillance, because they are likely to develop future cancer. At present, she is under vaccination, so I have called her after 6 months for the biopsy, and if the lesion is regressing, fine, others I will excise this whole lesion. You can see with the acetovite area. Since 26 years, physiotherapist, recently married, and wants childbearing. Can vulval pre-malignant prevention? Yes. The most effective prevention is vaccination. Smoking should be avoided. These are all lifestyle. It is depending upon the person. We can advise them to follow or not to follow. It is their wish. Personal hygiene, self-vulval examination is a very important part, and a gynecologist should make a habit to look at the vulva in a proper light. So this is self-vulval examination steps, where a patient has to sit in a lithotomy position and see at the 6 areas of her vulva. And if she cannot squat, then she has to stand with her legs apart. One chair she has to put her leg on the chair, and with a mirror she has to look in the vulva in the proper light. So complications are there with such type of surgeries and management. Recurrence is high. There are psychosomatic problems. Many times the patients coming with subtype lesions, and the husbands are getting very much curious. They are they also want HPV testing done. They also want, what we can say, you look at my private part and tell me if I have such type of lesion. So these things are there, and you have to counsel them. And the best part is when you see VIN or vulval warts, always vaccinate their partners. This is a necessary point, because it will prevent them for developing such type of lesions. And follow-up is very important. All vulval VIN dystrophy has to be under close surveillance. Carcinoma is is high in untreated than in treated women. Biopsy is mandatory before starting any treatment or going for laser therapy, anything, you do a biopsy. Treatment depends upon the type and extent of the lesion and patient's age. Treat the patient, not the lesion. That is my, always I tell people that you see a patient, just don't rush. You see the patient, see her complaint, see her history and go for the treatment. This is a case I want to just highlight. This was a 26-year-old woman. 2 years back, she had a small wart-like growth. A gynecologist removed and threw away the specimen. She was come from the remote area of the Gujarat. After 3 years, again she had such a growth. Again he removed and threw it away. Then after 1 year, she had such a huge growth on the vulva and a huge mass on the inguinal. Then she was referred to me. She was 120 kg, did a vulvectomy with a groin dissection and 8 centimeter inguinal node. We have given her chemotherapy, radiotherapy. She is under surveillance. Now imagine 3 years back when there was a lesion which was only 1 centimeter, if that doctor had thought about cancer, had thought about treating her, even if she had excised, but send her for the pathology, she could have been in stage 1. Now she's in stage 3. The doctor in the morning told, our main aim of screening is to prevent mortality. We have put her in a very bad prognostic area, 40% recurrence chance. So this is my message. Any lesion, if you are removing, send it for the biopsy. If you don't know, send to an oncologist. And this is my first HPV clinic with the latest EI-based colposcope. I do have a vulval clinic also. And this is Dr. Walter, who invented the lip biopsy. He visited my clinic. To summarize, vulval cancer should be prevented because they have a long period of recurrence or long period of what we can developing into cancer. Vulval lesions are difficult to interpret, difficult to treat. Identification of lesion is must, may require skill, require a multimodal treatment like a skin specialist, dermatologist, cosmetic, aesthetic. Each gynecologist should be aware of optimal modalities and need to correct the diagnosis and treat the vulval lesions. And if you have any questions, please ask me. Thank you very much.